Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange among Indigenous people. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. I'd like to remind you to please enter your questions in the chat at the end of the presentation. And please let us know that you were here today by answering a brief survey that will be sent to you immediately after the presentation. So we are fortunate to have a speaker today from the Division of the Physical and Rehabilitation Medicine. And would you please introduce our speaker?
Sure. So hi, everybody. My name is Mohan Radhakrishna, and our speaker today will be Jennifer Massad. So Jennifer Massad did training in occupational therapy before doing her medical degree at University of Sherbrooke, followed by residency in PM&R at University of Montreal. She runs our traumatic brain injury program at the MGH, which is one of the biggest traumatic brain injury programs in the province. And she'll be talking to us today about mild TBI, which you might have all had some either personal experience or family experience with. So Dr. Massad, please take it away.
Good afternoon, everyone. Thank you for the opportunity to present at the Grand Rounds, and thank you for the introduction, Dr. Radhakrishna. So today I'll be talking about mild traumatic brain injury and concussion. So I'll go over the most recent guidelines and updates, as there's been a few in the last recent years. Okay. Disclosures, I'm a médecin conseil for a neurotrauma for SAQ. Other than that, no disclosures. For learning objectives, so at the end of the presentation, the goal is to be able to summarize the basic epidemiology of traumatic brain injury, describe the new diagnostic criteria for mild traumatic brain injury from the American Congress of Rehabilitation Medicine that came out in 2023, discuss the early care offered for the management of mTBI and concussion, more specifically in Quebec. And then lastly, manage sport-related concussion according to the Amsterdam Consensus that came out in 2022. So there's really two different aspects to the presentation, as there's two entities that did updates in their guidelines. So the mild traumatic brain injury with the American Congress and the sport-related concussion group. And that's how I'm going to be presenting. So it's no surprise that traumatic brain injuries are a public health concern that have generated increasing attention throughout the years. We all know of someone who has had a concussion, a TBI, or have suffered one ourselves. And that's an article that was published in La Presse in 2022. So nearly 2,000 people a year suffer a traumatic brain injury that's moderate to severe in Quebec. And unfortunately, sustaining a TBI is quite easy. You can go in your car, get into a car accident, have a TBI. You can go outside, slip on ice, hit your head, get a TBI. So, and although rarely fatal, the mild TBIs can have significant long-term consequences for the patients. And that's why it's important to recognize them early on and to manage them accordingly. A little word on funding. And research. The government of Canada invests in a range of research related to brain health. And between 2018 and 2022, the Canadian Institutes of Health Research invested roughly $54 million in research on both TBIs and concussion. And the government of Canada renewed the funding recently in the federal budget of 2024 for $80 million over 4 years. And that was matched by the Brain Canada Foundation for a total additional of $160 million. So it's really a big health issue, and people are really considering it important. So just to go over the severity classification, we usually have 3 determinants for the severity, which is the Glasgow Coma Scale, the duration of loss of consciousness, and the duration of post-traumatic amnesia. We'll go over these 3 determinants a bit later on briefly, because the main subject of the presentation is mild traumatic. So we have the mild, the moderate, and the severe. For a mild traumatic brain injury, you have a Glasgow between 13 and 15, a moderate 9 to 12, and a severe would be 2 to 9. So with a mild traumatic brain injury, what you usually see is a relatively brief period of loss of consciousness, It says up to 30 minutes, but in reality, we see much less. It's a few seconds to a few minutes. The post-traumatic amnesia can be up to 24 hours, but again, realistically, it's usually a few hours, if any. So any injuries that are presenting with a loss of consciousness of more than 30 minutes, a Glasgow of less than 13 after 30 minutes, or a PTA of more than 24 hours are not considered mild TBI. There's also another name classification that you can come around to, is the mild complicated or mild complex TBI. I'm not really talking about it in this presentation, but it's a sub-classification of mild TBI where the imaging would be positive. So what is a traumatic brain injury? It results when an external force is applied to the head, leading to an injury to the brain structures and or a disruption of chemical and physiological brain functions. The definition, the whole starting point of this definition was in 1993, and it was developed by the Mild Traumatic Brain Injury Committee, which is a special interest group of the American Congress of Rehabilitation Medicine. And since then, so since 1993, we have seen a few different definitions with a lot of discrepancies. And that's why this work was done in 2023 to try to unify the definitions. So after 1993, there was a Center for Disease Control that came up with another definition. Then the World Health Organization in 2005. In 2021, the Veterans Affairs and the Department of Defense came out with another definition. And most recently, for the concussion, there was another definition in 2022. So overall, they all agree that a brief loss of consciousness is sufficient, but not necessary for diagnosis. But then they all vary between if the acute symptoms would be enough to diagnose a mild TBI or not. So we'll go over the new one mainly. So the Glasgow Coma Scale, you all know of it. It's the most common classification system for assigning the severity of the TBI. For the purpose of my presentation, the GCS is usually for 13 to 15. So you have a patient that comes in walking, so they're obeying commands, they're talking, they're oriented. Sometimes they're confused, so it would be verbal response of minimum 4, and then they're opening they have their eyes open. So you would never find anything less than that. And it's believed that the component with the most that's most associated with long-term outcomes is the motor response. The post-traumatic amnesia, it's the time between the injury and the ability to demonstrate continuous memory. So patients usually have a failure to form new memories before and after the injury. It's present in 25% of cases. And you can also find other symptoms in these patients like confusion, agitation, violence, aggression, disinhibition, and sometimes inability to recognize familiar people. And once again, that's one of the most powerful prognostic factors. So the longer the PTA, the less favorable the outcome is for the patients. And this is really, you find this really with the moderate to severe TBIs, not really with the mild traumatic ones. So some statistics, approximately 69 million TBIs worldwide each year. Of these, 75 to 85% are considered mild, with an annual incidence of 600 on 100,000, with 4,000 mild TBIs admitted per year. So it's a lot of patients. In Quebec, more specifically in 2019, that comes from the INSPQ, more than 45,000 individuals consulted at the ER or in clinic for mild traumatic brain injury. And that number is in constant increase since 2008. And of course, it also underestimates the real number of cases because not everybody consults when they have a mild traumatic brain injury. The causes of mild TBIs or TBIs in general are falls mostly, MVA, back accidents, and assaults. The causes vary depending on the age as well. So we will have falls mostly in patients over 75 years old and MVA in younger patients. There's a trimodal age distribution, so 0 to 4-year-old. 15 to 24-year-old with a 4 times higher risk due to high risk behavior. They take more risk, and 75 and up. The ratio male to female is 2:1, and it's been that way for a while. The reality at the MUHC MGH, so we see approximately 400 to 500 TBI admissions per year in the trauma program. That's from mild complex to severe TBIs, and approximately 500 new mild TBI cases at the outpatient clinic. And there's more admissions from June to September, with a constant increase in patient age 65 and up. That's just a small diagram of the severity of the TBIs. We see that these numbers are from 22-23. So we have mostly moderate TBIs with 34%, then mild complex 32%, severe for 12%, and mild simple 19%. The destination and discharge of these patients from, in 22-23, most patients return home. That's 34% of these patients. 29% are referred to inpatient intensive rehab in a TBI program. We still had 13% of people who passed away, unfortunately. 8% were referred back to their main hospital, and some just were sent to long-term care, 3% of them. There's also lits post-aigu, 5%, when they don't have specific needs in TBI, but they can't return home right away. From the proportion of patients that were sent home, 32% were referred to the TBI clinic, again at the MGH. 36% were sent without any needs for rehab, and 24% were sent to outpatient rehab, again in the TBI program. And some of them were sent back home with a CPA program, which is rehab but at home, when the patients have a family around. Okay, so that's the main subject of the presentation. So in 2023, the American Congress of Rehabilitation Medicine came up with a new updated diagnostic criteria for mild traumatic brain injury, and they updated the 1993 criteria. The objective of that evidence review was to create new criteria that would integrate the best available research from the past 30 years to address the limitations of prior definitions that were presented throughout the years, and to present something that can be used across the lifespan. So for kids, for adults, and for older people, and appropriate in both sports, civilian trauma, and military settings. At the same time, Quebec followed in the footsteps, and they updated their guidelines as well. We'll go over this a bit later. So this is a flowchart that you can find in the article, and it shows the different pathways to diagnose the mild TBI, which is the black little box. We'll try to go over this as less as confusingly as possible in the next few slides. In general, what the flowchart shows is that the mild TBI can be diagnosed when you need first a plausible mechanism of injury. So that's criteria number 1, with one or more of the criteria below. So you can have one or more clinical signs, at least 2 acute symptoms, and at least 1 clinical or lab finding, imaging evidence of TBI. And you have to have the confounding factors cannot fully account for the clinical symptoms, the clinical signs and the symptoms that you find. So let's go over each and every one. So criteria 1, mechanism of injury. What is a plausible mechanism of injury? It's any transfer of mechanical energy to the brain from external forces that results from either a head being struck with an object, the head striking a hard object or surface, the brain undergoing an acceleration, deceleration movement without direct contact. And that's a new thing from 2023. You do not have to have a direct contact to consider it a plausible mechanism of injury, and forces generated from a blast or an explosion. So once you have this criteria, you can only have one or more of these signs, and you're set to have a diagnosis of mild TBI. So You have the loss of consciousness that is immediately after the injury. An altered mental status, again, immediately after the injury, that would be like reduced responsiveness, slowness to respond, agitated behavior, inability to follow two-step commands. This is what you're looking for in these patients, or simply being disoriented to time, place, and situation. Complete or partial amnesia for events immediately following the injury. And sometimes you can't really assess that because the patients are either too comatose or there's a polytrauma, there's some sedating medication. So you can use the retrograde amnesia for that. And other acute neurological signs that would be, for example, incoordination on your examination, seizure, or tonic posturing. Okay, so like we said, if you have the mechanism of injury and then you have one or more of these signs, you're set. If you don't have these signs, you can have two or more of these acute symptoms with one or more laboratory findings or exam findings. So I will go over the exam findings after. So the acute and subjective altered mental status with the patient reports feeling confused, feeling dazed, feeling disoriented. Physical symptoms, so the patient reports headache, nausea, dizziness, vision issues, sensitivity to light or noise. Then you have the cognitive symptoms, like feeling slowed down, difficulty concentrating, memory issues, emotional symptoms, like the lability or irritability. And these symptoms must be new or worsened, and they have to have happened in the first 72 hours. Anything longer than that, it's not, we can really have a cause to effect. And they can be better accounted by other confounding factors like alcohol, medication, or pre-existing health injuries. This is the other criteria. So you would need two or more of these and one or more of this to be able to have a diagnosis. So cognitive impairment on examination, balance impairment on examination, oculomotor impairment, or elevated blood biomarkers that are indicative of intracranial injury. So the last part, this is, there's really insufficient research evidence to use these biomarkers. So I'm not even gonna go into that. We don't use this at all in our practice, but it's something that we can look forward to with more research. The criteria number 5 was neuroimaging. So any trauma-related intracranial abnormalities is enough to diagnose a TBI. So subarachnoid, subdural, epidural, but it's not necessary to diagnose it. But if it is present, then it is a TBI. The other thing that they add in this new in this new review is the diagnosis of suspected mTBIs, and that comes complicate a bit everything. They say that it's possible when the only evidence that you have is self-reported symptoms, but that you have a high suspicion of a TBI. And unfortunately, that reflects the reality of medicine. It's not always clear cut. It's often not black and white. So if a suspected mTBI is identified in the first few days, then you just go ahead and treat it as such. So it goes with the mantra: when in doubt, sit them out. It's better to prevent any long-term consequences than to not act on it. So yeah, so this paper in 2023, they consider a concussion a mTBI if imaging is normal or not clinically indicated. The INES, which I'll be talking about in the next slide, they updated their pamphlet also, and they consider a concussion a mTBI for the sake of simplification for the general population. So they use the wording mTBI concussion. In the Amsterdam Consensus in 2022, they don't really mention what is a concussion versus an mTBI. So this is the new updated pamphlet from INES. You can scan it and take a look at it. So the last version was done in 2018, and why they updated it because of the new guidelines that came out in 2023 and from the Consensus of Amsterdam too. So they try to update as much as possible with the new evidence. The main differences from the 2018 pamphlet is that the initial rest period is of 1 to 2 days versus at least 48 hours. And you try to have an active rest. And so it's no longer being told to patients that you have to be in a room, in a dark room, do not move, do not look at screen, do not do anything. That's not the best thing to do. And it also gives advices on possible activities during the initial rest. In the old pamphlet, you only had the activities that needed to be avoided or limited, so people were a bit confused. And it mentions that any increase in symptoms, as long as they're mild and less than 1 hour, are tolerated, and the activity can continue to progress. So now let's go to the second part of the presentation, the concussion and the newest updates from this concussion in sport group. So the CISSG, this is a group that for over 2 decades has had meetings every 3 to 4 years to update the recommendations and statements on concussion in sports. So the first meeting was done in Vienna in 2001, then Prague in 2004, 2008 and 2012 in Zurich, then Berlin in 2016, and most recently in Amsterdam in 2022. There's been a gap of 2 years extra because of the COVID, but they've been working on it since 2020. So here's a consensus statement that came out, and it was published in the British Journal of Sports Medicine in June 2023, and it builds on previous concussion in group statements, like I said before. So the way they present their studies is with the 11 R's of sports-related concussion, and they added 2 more to the new recommendation. So I'll go over every single one of them. It's just an easier way to see how to manage the concussions. So the first step is recognizing the symptoms and signs of a sports-related concussion, and it's perhaps the most essential step in the management of SRC. So what is a sports-related concussion? It's a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. So we're really more in the sports category here. And it's a conceptual definition. So there's really no diagnostic criteria for sports-related concussion. So there's a recent study that found that athletes who waited over 1 week to seek medical care took approximately 8 days longer to fully recover than those who presented after the first week, or within the first week. That's a study in 2020. So the importance of recognizing concussions is really for long-term purposes. So that's the definition again. So symptoms and signs may present immediately, evolve over minutes or hours. It typically resolves within days, but they may be prolonged in 20 to 30% of cases, which is a lot. And there's no abnormality on imaging, so nothing, no bleed, no subdural, no nothing. And it results in a range of clinical symptoms and signs that may or may not involve a loss of consciousness. The clinical signs that you all know that you can find in this patient, and they can be explained by drugs, alcohol, medication use, cervical injuries, vestibular dysfunction, or psychological factors, coexisting medical conditions. So there's a lot of overlap between the symptoms of, let's say, depression, anxiety that you can find as well in patients with the concussion. So it's always important to try to differentiate what is what. It's more likely to occur in contact sports with the highest incidence in soccer, football, ice hockey, rugby, and basketball. And that excludes, of course, the combat sports where it's really a major issue. So the other R, which is reduce, how to prevent a concussion. So it's been shown that implementing primary prevention across all levels of sports is a priority that can have a significant public health impact by reducing the time to recovery. And in the past 5 years, there's a threefold increase in studies examining the effectiveness of the prevention in sport-related concussion. What's been shown is that you can act on either policy rule changes, personal protective equipment, and training strategies. So that's a study that was done in 2023 that goes over the different prevention strategies. Here for the policy or rule changes, what came out is that let's say for ice hockey, if you disallow body checking in child or adolescent ice hockey, it decreases the rate of concussion by 58%, which is it's considerable. To limit the number and duration of contact practices and limit the intensity of contact in practices, they've all shown to reduce the rate of concussion. And in American football, it was shown that restricting collision time can also decrease the rate of concussion by 64%. So there are ways to prevent concussion, and that should be their main priority. Personal protective equipment, the only thing that was shown to really decrease the rate of concussions are the mouth guards. So the way it works is that it creates a space between the jaw and the base of the skull. So it helps protect the brain from concussion by preventing the jawbone to slam into the skull, and that way they're creating shock waves into the brain. So there's a rule that it should be mandated in child and adolescent ice hockey and supported at all levels of play. For the helmets, which is something that we all hear, it's the effectiveness for reducing sport-related concussions remain unclear, unfortunately. So it can protect your brain, it can protect your skull, but the movement inside, they still happen. So it would decrease the risk of severe head trauma, but not necessarily decrease the concussion rate. So it requires additional research, but so the only real one that was shown is the mouth guard. The next R is the remove. So any athlete with a suspected concussion should be immediately removed from practice or from the game and should not return to that activity unless they've been cleared by a healthcare professional on the field, if it was during the game. And they should not be left alone or sent home by themselves. They should not be drinking alcohol, of course, and they shouldn't drive until cleared by a healthcare professional. The signs that would warrant immediate removal from the field, from the game, would be an actual or suspected loss of consciousness, seizure or tonic posturing, ataxia, poor balance, confusion, or behavioral changes that you would find in the player, or amnesia of the event or anything before. So that's what is used on the field. So that's the sport concussion assessment tool, and it's been updated again. We're the 6th version in 2022. You can take a look. I won't go over everything. But I'll just mention the red flags, which is a bit what I just said. So if any of these happen, you should refer the patient to a hospital care setting. So neck pain, seizure fits, convulsion, loss of consciousness, increased confusion, repeated vomiting, increasing headache, of course, any deformity of the skull or weakness, numbness in extremities that would warrant a referral to the hospital. The SCOTE, which is the Sport Concussion Office Assessment Tool, is really what we are brought to use as physiatrists, because it's done at the office and 72 hours to 30 days after the trauma. We rarely see the patients when it happens. So that's what we use, and it's been again updated, and it's the 6th version. So I'm not going to go over it here, but mainly what we go over, it's a full history of previous injuries, previous mental health disorders, previous learning disorder, ADHD, anything that could exacerbate the symptoms of the patient. And then, of course, a full neurological exam, cognitive exam, as much as possible that can be done in an hour. So you would have the immediate memory, let's say month in reverse, any specific memory testing that you can do. And that can be serially repeated every time you see the patients, you see how they progress. So next, there's the other R is rest. So it's the evidence have shown that recommending strict rest until complete resolution of symptoms is not beneficial. So like I was saying before, it's no longer recommended to go to not do anything for a few weeks. So it would be a relative rest for 24 to 48 hours where the patient can resume his regular daily activities, cognitive activity, and limit screen time. And so the symptoms, we accept any exacerbation of symptoms for 1 to 2 on 10 scale. And it has to be brief, so it has to resolve in an hour. So anything that would make symptoms last for longer would be restricted. And they also came out with the recommendation of aerobic exercise as treatment. So after 48 hours, you can start training again. It facilitates recovery within 2 to 10 days, and it prevents persisting symptoms. So from a rehabilitation standpoint, any patient with persisting symptoms for more than 4 weeks should be referred to a rehab team to better manage the symptoms. That usually what the symptoms are is like headache, neck pain, dizziness. Those are the symptoms that would last longer in these patients. And it was shown that rehabilitation can be is beneficial to treat this, and always in combination with aerobic exercise. So again, who to refer to the interdisciplinary team with an expertise in concussion. Just a word on persisting symptoms. Like I said before, it's up to 20 to 30% of cases where symptoms can last up to 4 weeks. So it's a lot of patients that can return to work, can return to sports, can return to school. So it's really important to recognize these symptoms and to refer them when necessary. And again, it's important to differentiate what is really trauma related or really more of a pre-morbid factor like psychosocial or psychiatric issues. This is a list of the risk factors that you could find that would exacerbate these symptoms. So it was shown that female are more at risk of persisting symptoms, pre-injury pain, psychiatric history, insomnia before, lower resilience, the age, so the older the age, CT findings, of course, it makes it worse. PTA that is longer also. So important to take a look at that. So where to refer? We have these teams that are called équipes précoces d'intervention et de réadaptation en TCC léger et commotion cérébrale. So you can find these in a hospital setting. There's a nurse practitioner, physiotherapist, neuropsychologist, psychologist, and a physician. If you don't have this team available, then you can refer to first-line doctors, sports medicine doctors, or first-line nurse practitioner that can have an expertise in this. More specifically, here is for the adults. So you have this Hôpital Sacré-Cœur, then you have the MGH, and for children, you have this Saint-Justine or Children's Hospital. So anytime you have a patient with mTBI with persisting symptoms, it's important to refer to the right place. So recovering, most athletes return to sports within 10 days, most recover within 1 month, and the strongest and most consistent predictor of slow recovery is the severity of the initial symptoms in the first few days. And any individuals with history of mental health or migraines, like I said before, are at a greater risk for prolonged symptoms. ADHD and learning disabilities, they haven't shown a greater risk of persisting symptoms, but it requires a bit more planning and intervention to be able to return these patients to school or even to work. And that's where our neuropsychologists can help a lot with these patients. So return to learn. The reintegration of athletes into their academic environment can have a significantly positive impact on the recovery process. The longer you're out, the more difficult it will be to go back in. And 93% of athletes of all ages achieve full return with no additional academic support by 10 days. So it's pretty good when it's when you recognize it quickly. So for people that unfortunately are not able really to return, there can be some adjustments made to the environment, physical adjustments as well, and program adjustments. So anything like breaks from cognitive tasks, limited screen time on devices, avoiding contact sports, collisions, and extra time for homeworks or for exams can be allowed for these patients with a medical note. So since the beginning of this consensus in sports group, there has been strategies for return to learn. They have updated it a little bit, but basically it stays the same. It's a four-step process. Usually it takes 24 hours between each step. I'm just gonna let you take a look at it. I'm not gonna go in full detail, but it's a stepwise process. And the same thing for return to sport. The only thing that was changed in the recent updates is that now there's a three-step. The first three steps are considered a treatment phase, and you have to be really cleared, absolutely no symptoms, to be able to go to the 4, 5, and 6th step and return to the actual sport you were doing. And even when we're doing the best job that we have with the best tools that are available, unfortunately, athletes are still getting re-injured when they return to play, and that's something we can't really prevent, unfortunately. Reconsider. So there's an increase in societal concern about possible problems where later in life brain health in former athletes. So anything with mental health problems, cognitive impairment, neurological diseases. And the most recent research shows that neither amateur or professional athletes are at increased risk of mental health disorders or suicide. They're not at greater risk of neurological disorders, but there's a slightly higher incidence of neurological disorders described in some professional American football players and professional soccer players. Again, there needs to be a bit more research to be able to really find the cause to effect, but it's been shown that there's a slight higher incidence. I will not be talking about the CTE, so chronic traumatic encephalopathy, but that's been something that came out a lot in recent years, and again, it needs more research and needs more evidence. So we'll leave it at that. The other thing that was added to the consensus, so that it's the retire part, there's no clear evidence of what would lead us to retire from a certain sport. So it should be an individualized and shared decision-making process between the player, the coach, the parents when it's required. And it should include a clinical evaluation that considers a lot of factors like the athlete's risk tolerance level, his preferences, the type of injury he had, the sport that he was playing, ethical, social, cultural factors. So it's never black and white. So take-home messages. There's no universal definition of mild TBI. We worked throughout the years, with the most recent one being in 2023 with the new diagnostic criteria. Concussion can be called a mild traumatic brain injury if there's normal imaging or if it's not clinically relevant. Concussion in context of sports, you have to use the new assessment tools like the SCOTE 6. That's what we use. mTBI is frequent, constant, and increase and is underestimated. The INES updated the pamphlet, so it's easier for everybody to use it. So it should be now. It only came out on November 4th, so it should be now. We will be able to give it in the ER or at the Montreal General Hospital too. And if anything persists for more than 4 weeks, then refer to be able to manage accordingly these patients. Thank you.
Fantastic. Thank you.
Wonderful. Thank you. Please, you can enter your questions in the chat. Are there any questions in the room? Because I'd have a couple of questions for you. So it seems that, there's just a lot of people who use the term concussion. And I mean, if I look at, my social surroundings, everybody has a child that has had concussion. And obviously, with concussion can potentially come secondary gain. I'm just curious, in your practice, do you feel that, that there is a lot of, secondary gain, prolonged exams, time off work? It's so vague because, you have normal imaging, you don't have concrete findings. Can you just talk a little bit about that and in your reality?
So yeah, that's the main problem with this definition. It's really a conceptual definition. You don't have diagnostic criteria for concussion, and it's been interchangeably used as concussion, mTBI, so it makes it difficult. But to simplify it, any concussion can be considered a mild TBI, but you have to just be careful of the mechanism of injury. It all comes back to the mechanism of injury. So a person who hits his head on a cupboard when he's in the kitchen versus a high velocity car accident, you shouldn't have the same symptoms, even if both don't have a positive image. So for your question about secondary gains, we unfortunately have some people that do present with this, and we usually can determine that by sending them to our neuropsychologist, where she can take a look at more the cognitive aspects or the mental health issues. And there, in the clinic, she's able to differentiate what is really related to the TBI or what is from pre-morbid conditions. Are we able to 100% determine? No, but you have to. I tend to send these patients as quickly as possible back to work, back to school, but I present it in a progressive kind of way. So I tell them that if you wait too long, it's going to be even more difficult. So I tend to return them after a month of being off. I tend to start progressively returning them to work, like half days, 3 times a week, and then progressively increasing. I see them often every 4 to 6 weeks until they're back to work.
Okay.
The patients that don't go back and that I see there's secondary gains, I try to send to outpatient rehab to have a more of a multidisciplinary team approach and to prevent this chronicization of symptoms.
There's questions in the chat. Where does the shaken baby syndrome fit in with the concepts you have outlined?
Yeah. This is not really, it hasn't been touched at all in these 2 separate reviews. So I wouldn't be really able to tell you. It's the same principle of acceleration, deceleration movement, and it would be considered a traumatic brain injury for these for the babies, but it's 2 different entities, and I'm not really in the pediatric population, so I wouldn't be able to answer it.
There's a question here about, are there ongoing discussions with Hockey Canada about mandating mouth guards for kids hockey? Curious why it's not been mandated yet.
So from my knowledge, yes, there's ongoing discussions with Hockey Canada for that. And for the for the helmets as well, but it's already there. But yes, there's the ongoing discussions. Why it hasn't been mandated yet, I'm not too sure.
You want to
But
make a
it's,
comment, Mohan?
I don't know personally, but my kids always had to wear mouth guards. It was mandatory.
Oh, yeah?
Mandatory,
Not,
yeah.
I think it varies across different leagues or different levels. So it was the studies that were done, it showed that it's from the bantam level and up that you should start having like permitting contacts, and before that you shouldn't. So maybe it's a question of age and level of, but there's ongoing discussion with health and
Okay. Do you have any comments or information on a saliva test that has been developed to diagnose concussions? Interesting.
Yeah, that came out actually very, very recently in the news. There's no paper or more information that was given, but that was mostly for also to be able to recognize the CTE. So I don't have more information, but it's really ongoing as we speak now.
Oh, very interesting.
Yeah, and I can give, I do have the name of the studies that's being done, but yeah, they didn't give the specifics of what test it is.
Okay. David Rosenblatt has a question about the issue of permanent brain damage in professional football players with recurrent concussions has gained prominence. Are you saying these concerns are overstated? There is a great incentive for players to keep playing. Overstated.
Overstated. So I know there's also a lot of it's a big issue. I know that the rugby players and the football players they started a lawsuit against the league because of the potential that they were potentially hiding the long-term effects. So no, it is quite a real concern. But the research right now hasn't been able to show a clear-cut cause to effect. But there are researches being done as we speak that will probably make it a bit more evident that there is a relationship between that, and there should be more prevention on that level.
For the parents I know that you don't do pediatric.
I don't do peds. I do up as of 18 year and up. I do see them. Yeah.
But nonetheless, for the parents in the space who have their kids playing sports, are there any that you would avoid? It's question number one. And number two, could in kind of routine playing for sports, not professional. Do we have objective evidence? I know that, in some schools they do pre-sports cognitive testing and yearly cognitive testings. What do we know about that? So 2 questions.
Which sports you should avoid? The boxing and for sure these sports are the one I haven't even touched about that because it's clear. It's obvious. It's obvious that these sports are the number one sports that you should be avoiding, and then it's up to the risk tolerance of every person, right? So hockey, there's no evidence that stopping a sport because of one concussion will be beneficial, because the benefits of being active physically is way more important. So no, so I would say hockey. That's one, and American football, which we don't see a lot in Quebec, but those would be the 2 that you would avoid the most. But I wouldn't never recommend to the patients to not play,
because you feel that the benefits of the physical activity
outweighs the risk. But then again, are we talking about one concussion, or are we talking about are we at the 13 concussion in 1 year? That's also something that you have to take into account. So a patient that just came with one concussion, you would tell them to, be careful as much as possible and not return them to sport until really cleared. But after the 13th, we can have I usually have a discussion with the patient and the parents, and I'm like, what do you think? Do you want to continue? And because there's also the school at the same time. So if it's impacting school as well, then you have to make a decision, a logical decision. Yeah.
Okay. And on terms of my second question, which was the
Yeah.
cognitive testing, I know
Yeah.
that Scott Delaney, I think, and his group are
Yeah.
doing,
Yeah.
these kind of manual for kids. Yeah.
Pre-training and
Yeah.
post-training.
Have they seen anything yet? Is there any data on that?
I wouldn't be able because like I said, I don't do peds, but in adults, we don't really do pre-sports. We sometimes use a MOCA that was done in the last few years, maybe if you want to compare it, but I wouldn't be able to tell you more specifically for peds. Sorry.
Fantastic. Any other questions? Yes.
Yeah, you mentioned blood tests. Are there any simple blood tests?
No, nothing simple. So I have the names of the blood tests, and honestly, I've never seen them in my
I
practice.
see. They're not regular tests.
They're not regular
I
tests.
see.
So you have. I'm not even going on the right one. So there's like the gliofibrillary acidic protein, the UCHL1, and the S100B. Those are really not typical ones. Those are the ones that have been studied. But again, they need a lot of research still. But these are the ones they're studying right now.
So the spinal fluid examination.
For the shearing of the actin.
Spinal fluid examination.
It wasn't brought up in any of the no.
Thank you.
Okay, if there's no other questions, then I'd like to thank you very much for a really terrific, comprehensive lecture on this very important topic. So thanks everyone for attending, and I wish everyone a great afternoon. Thank you, Jennifer. Thank you.
Thanks, Jennifer.
Super interesting.